I'd probably like to talk about what happened in the Philippines on health financing from a perspective that goes all the way to the 1940s. Because sometimes we forget that the call for universal health coverage is something probably like when you write the Right for Health that came out in the late 40s and the early 50s. That's essentially what it was calling for. Of course, eventually we call it health for all, and whatever discussion semantics is, for me it's quite the same. It's essentially a desire for all people, well, all Filipinos if you want it, to have access to healthcare. I think the big difference, of course, is that when we now talk about universal healthcare, we have a much more comprehensive view.
Sorry. Can you hear him? No?
Okay.
Is there a technical problem?
Okay, I'll do this now.
Yeah.
Okay. I could start again if you want, Paul. I'm just trying to say that Paul's probably as old as the 1940s. That essentially, okay, I'll go back. That essentially, when we talk about universal health coverage, sometimes we sort of think that it just started recently. No, that it's been, I always believe it's something similar to the call for the right to health, to the call for health for all. And it's really a desire for, for countries, for governments, the Philippine government in particular, to make sure that every Filipino would have access to healthcare. The one difference we have when we talk about universal health coverage right now is that it's a much more comprehensive analysis of what should be there. It's not just, in a sense, a more limited services or probably just primary care services, but a much more comprehensive services that should be there. And of course, much more clearer understanding of financial protection. So the way we look at it, the way the Philippines has been trying to solve this since the way back, since the 1950s. I was born in the late 60s, so probably I'm too young for this. But essentially, it was an option whether you have a supply-driven or the way I love to call it a provider-centered approach or demand-driven solution. This is a patient-centered approach. This is my own analysis of how things happen in the Philippines, so you could sort of disagree with me. And in the sense, when you try to talk about a supply-driven solution, this is what the country has been trying to do since the 40s, the 50s, the 60s, and the 70s. So how do they solve it? Okay, they try to put more money into the system from government. You try to build your own health facilities. You try to hire more doctors. You try to put doctors in remote areas. You try to increase efficiencies by devolution, decentralization, and we have a massive decentralization in the Philippines. You try to make better access to drugs. So the main component usually of the strategy is generic competition, and try to make. You try to improve procurement, because in procurement, that's where a lot of inefficiencies usually are in procurement. You try to have better information, and usually you can do that if you invest in IT, and you try to change the way you allocate budget. So there's a lot of shift right now on the supply side on performance-based allocation. And in a sense, the way I always love to emphasize, the problem with this, of course, that the center is still the provider, and a lot of the discussion within the Philippines is that you don't usually talk about the patient per se, but how do you improve the healthcare provider. So what happened essentially, and I think this is probably something that happened in the 60s, the 70s, essentially what happened in the Philippines is that, yes, using this approach, we did wide with the question mark, because we actually got to cover lots of Filipinos. The vaccination programs, the public health programs, the maternal care programs, it covered a lot of Filipinos, but it was essentially shallow and low. There was a lot of user fees, and there was a limited number of services. And a lot of the services that are actually available to Filipinos are the public health programs, the TB program, the malaria program. But when you start moving into hospitalization care, it was just not there. We start talking about chronic care, chronic medications for NCDs, it was just not there. And so the question, and there seems to be something which I don't know, can you see the slides? So it's like there's sort to be sort of a spiraling down. As we tried to fix as well, the older Filipinos tried to fix the system. What essentially was happening was there was inadequate quality and quantity, and I think partly driven by the fact that the incentives in a supply-driven system is that there's no incentives really for healthcare providers or for health providers and for professionals to do anything extra. You get your salary. If you see one patient, you see 10 patients, you get the same salary. You get better services, improve quality, you don't get anything, you don't get a promotion. So naturally, the incentive is that the quality and quantity decrease. And what usually happens is as the country's economy grows and the middle class started expanding, most of the middle class in the country starts moving out of the system, start demanding for other services outside of government providers. And in the Philippines, that led, of course, to the growth of the private sector. And I think we're also going to see it in Bangladesh. As the middle class starts expanding here and became unhappy with the kind of service that they're getting in government services, they start demanding it from outside, and then by the power of the market, you start having private providers coming in and opening hospitals. I think we're seeing that already. In the Philippines, what happened is that eventually the middle class starts, of course, encountering large out-of-pocket payment, and that led to the demand for the clamor of formal health insurance. This led to the Medicare in the Philippines way back. This is the original social health insurance program way back in the early 70s. As the Medicare, as the middle class essentially gets moved out of the system, then you have, I usually call them the noisy ones. They're the one that usually clamor for better services. And so, in a sense, the government healthcare services in the Philippines essentially became a services for the poor. And the poor is not as empowered as we want them to be. And unfortunately, that lead to more deterioration and probably still wide, but more shallow and lower services. And so the question that was there in the country around the early 90s was, can we still fix it? Can we still fix the supply side approach by putting more money into the system? So was it just a question of money? Was it just a question of efficiency? Can we actually improve the efficiency of the supply side approach? And it's a question that sort of people were grappling around the early 90s. Then, well, some people say, why don't we just change the whole approach? Why don't we, of course, you cannot just undo everything overnight. Why don't we start putting in sort of a patient-centered, a demand-side approach? And essentially here, where the center is the patient, where instead of, it's like flowing the money to the patient. And so what happened in the Philippines is in 1995, we actually have sort of a demand-side solution, which I always like to call patient-centered. So a law was passed in the Philippines in 1995. It's called the National Health Insurance Law. The law created a national agency. It's an autonomous agency. It's a government corporation called PhilHealth, called the Philippine Health Insurance Program. But in the Philippines, everybody has a nickname, so it's called PhilHealth. The law is a single fund. Sorry. It's an autonomous corporation. It is attached to the Ministry of Health or the Department of Health. We call it Department of Health. The Secretary of Health, which is the minister here equivalent, is the chairman of the board, but it doesn't run it. It has a president and CEO, and it's the board that makes the decision. I was the president and CEO of PhilHealth for a couple of years. It has a governing board, and the governing board is the one that sort of provides the policy guidelines. But of course, since the secretary is the chairman, he makes sure that most of the things PhilHealth does is consistent to what the Department of Health, of course, national policy demands. It's a single risk pool. It's a single fund. Everybody is supposed to be part of the program, and it took, I think, there was a 1-year delay because the formal sector insurance, which was Medicare, resisted to transfer the money. But after a while, they actually agreed, and so now everybody pays into the fund, whether you're formal sector, informal sector, or the poor. The poor are subsidized, so explicitly, the poor are supposed to be subsidized by government. And since the Philippines has devolved and decentralized a lot to local governments, so the subsidy has to come from both the national and the local governments. There's a cost sharing. But recently, it has been changed, not by legislation, but by Budget Act. So since there was problems trying to convince local governments every year to get them to pay and subsidize the poor, the national government took it upon themselves to subsidize the poor 100%. And to fund it, as an amendment of the sin taxes happened, including alcohol, and 85% of the incremental increase, so whatever was collected for the year, anything over and above that, 85% of that was now going to the health sector, and 80% of that money is going to fund the premium for the. So there's a tax now that's directly earmarked to fund for the enrollment and the subsidies of the poor, 100%. The local governments can still subsidize anything they want, but they now have to pay 100% of the premium. It's a family-based membership, so you don't enroll as a member, as an individual. You're a family. Right now, because I am no longer in the formal sector in the Philippines, my wife is the member. I am her dependent. And my children, because they're less than 21, are also dependents. And her mother, who is more than 60, is also dependent. So she's paying a premium, but 1, 2, 3, 4, 5, there's 6 of us who are essentially members of the program. So it's a family-based membership, and it has, in a sense, facilitated the expansion of the program quite rapidly. So when I left PhilHealth, the membership base was about 20 million Filipinos. We're now hitting about 84 million. That's about 86% of the total country. With the sin tax earmark, they might hit probably 95% soon. It always, it contracts, so it used the word used to be accredit by historical, because Medicare used the word accredit, which is not really accreditation per se, but really a form of soft contracting. But PhilHealth contracts with both public and private hospitals. It's not, I think one of the difference we have with Indonesia for a while with Jamkasmas is Jamkasmas really utilized only public providers initially, right? But not anymore, for profit. Now, in the Philippines, it's something we have to live with because 50% of our hospital beds is private. 70, and so if you don't bring the private sector, what's the point? So we actually contract with both private and public providers, and usually the way it's done is that within the contract, you have agreements on how payments are done, rates are included there, rules, and all of those stuff. It works with NGOs because, like Bangladesh, we do have a very vibrant, very robust NGO sector and microfinance organization, but they don't usually operate. We have reached a point that they don't operate micro health insurances anymore, but they're sort of accepted that they be part of PhilHealth. And the usual relationship is that they collect in behalf of PhilHealth. So they collect money, the money is pooled into PhilHealth, but they could have branding. So let's say, for example, one of the biggest is card. So it's a card, becomes a card health insurance. And the benefits is quite comprehensive. So why did the Philippines do it? Well, shifting to a demand side is empowering for the member. It generates demand for quality. We have seen it incentivize quantity, improve quantity and quality. And of course, you have access to private providers. And it actually, for public providers, have more flexible financing cycle because you're not tied to an annual budget. There are a lot of things that happen, but one of the things we found out, the fact that we were able to push retention of the payment of PhilHealth by public providers was key. And it was much more easier for us to push for really explicit no out-of-pocket, including, medicines would always be there, diagnostics would always be there. We don't say no out-of-pocket because the things are not there. So what we're seeing is that by doing what PhilHealth, the combination of PhilHealth, one of the things we actually did, by the way, is that the supply side, it was not like Thailand, where the money for the supply side was shifted fully to the demand side. The budget for the supply side continued. So it's essentially new money, but when new money was generated, it went to the demand side. And so because of that, we were able to do wide, tall, and deep. There's still problems. It's 18 years now. I've been working in PhilHealth since I was in PhilHealth and I left, joined the World Bank, then came back and out. So I've been in and out for about 12 years. But there's still problems. Unfortunately, despite 18 years of health insurance, people still don't understand it. It's still a difficult topic to understand for a lot of policymakers, and the process to continue to educate them will be never ending. There's a lot of innovations that we're doing, but it's just quite difficult to scale up. The funding, there's still, because supply side funding is still ongoing, so sometimes there's still a lot of overlapping and confusion, and we have to resolve that. There are always a continuing demand for more benefits, and Indonesia is feeling that also. And then, so combined with that, it's difficult to increase premiums. And of course, there's still a continuing discussion of who pays what, like shall it be, because we still have both supply and demand side money flying in, so there's always that over. And finally, we, like Bangladesh, we have a lot of migrant workers, and we're able to get them to pay premiums into PhilHealth they're required to pay PhilHealth before they leave the country. And so this has created problems. They're doing that, it's mandatory, but sustaining it has become quite a political problem. Finally, what we did in PhilHealth is in order to make it really, as Jan said, it's political. And when you start talking political, then you better brand it so that it's so politically acceptable by the people. And one of the things we did in PhilHealth is we have this battle cry, bawat Pilipino membro, bawat membro protektado, kalusugan natin sigurado, which in 9 words makes it easy for us to understand. So if this is only 15 seconds, you can explain in an elevator. So what's in PhilHealth? What's universal healthcare? Essentially, each Filipino member, each Bangladeshi member, each member protected, our health secured. And that has become the battle cry of PhilHealth, and that's how the program is now being explained all over the country. And of course, we do good branding. So for example, we use this a lot now. So universal healthcare for every Filipino. When you see it anywhere, including the vehicles of PhilHealth, you can easily grasp what it's trying to aspire for. Then of course, we have this nice logo of of a person running, because the urgency towards universal health coverage should always be felt. And then you have coverage, and of course, the sort of a gloves. Nice colors. You could also have those kind of things here. So that's the health financing story of the. It's a continuing story. Okay, 100 million people. It's not that easy to continue and sustain coverage. But I think a story that seems to have a very nice ending. Thanks a lot.